One of the things I think that's very exciting is that the newer BTK inhibitors that are emerging, acalabrutinib, and we haven't talked about zanubrutinib, but it's on the immediate horizon. But these newer generation BTK inhibitors, and I should also say there are several in development, are really suggesting to us that we have more tolerable therapies that will translate to better outcomes for patients if they can stay on the treatment for as long as possible. So there is a difference between these agents. Right now we have 2 approved agents that are BTK inhibitors. They're what we call irreversible or covalent binding BTK inhibitors. They both bind to the Bruton tyrosine kinase binding pocket in the exact same way with the exact same amino acid contacts. We're talking about ibrutinib and acalabrutinib. But what's different between these tyrosine kinase inhibitors is that they have different kinome profiles or kinases that they hit as off-target binding sites. So certainly we want them to be very selective for BTK, and ibrutinib and acalabrutinib are both highly selective for BTK. But acalabrutinib is actually maybe what we would call a cleaner kinase. It hits fewer off-target kinases than ibrutinib. That may be an advantage. You could argue in some cases it might be a disadvantage. But in general, the idea is that if you can hit fewer kinases, fewer off-target kinases with your tyrosine kinase inhibitor, like acalabrutinib, that maybe you will have fewer side effects. And the early data, albeit it's not head-to-head comparative data, suggests that maybe the acalabrutinib might be better tolerated than the ibrutinib. So we know that if you look at a kinome profile or a map of the kinases that each of these drugs interact with, there are way fewer kinases that are interacting with acalabrutinib than there are with ibrutinib. And in fact, we are able to assess the tolerability of these agents through the trials that we've done. The ELEVATE trial, the frontline trial of using acalabrutinib either with or without obinutuzumab, was again compared to chlorambucil and obinutuzumab, and the efficacy was outstanding, about a 90% reduction in the risk of relapse, progression, or death if you got acalabrutinib with obinutuzumab versus the chlorambucil-containing regimen. Significant, outstanding efficacy, very similar to what we see with ibrutinib as well. What was very important from the ELEVATE trial, I think, in fact, perhaps most important, was the outstanding tolerability of the therapy. Less than 10% of patients have to discontinue treatment with a median follow-up of about 2 years or 2.5 years. Tells you again a lot about the tolerability of the therapy. And if you look at the adverse events, they're almost always grade 1 or grade 2. Most of them are usually self-limited. There's some myalgias, arthralgias, perhaps a rash, but their rates are very low, and they may be simply very low because you're not hitting all of those off-target kinases. As an example, we know acalabrutinib does not target EGFR, and so we see relatively low rates of rash or diarrhea because we're not hitting EGFR. We also, of course, are always concerned about more serious adverse events, serious related adverse events due to the BTK inhibitor. And in the ELEVATE trial, the rate of atrial fibrillation was very low, about 2%. Certainly need to follow patients for a longer period of time, but a very encouraging low rate of atrial fibrillation, relatively speaking. And bleeding as well. Major bleeding was on the order of about 2% as well. And that was very similar whether you were on an anticoagulant or an antiplatelet agent or you were not. Major bleeding, very low with acalabrutinib. Overall bleeding, such as bruising, contusions, or other other signs such as purpura, was on the order of about 8% or so. So we do know that the ELEVATE trial shows us outstanding efficacy with acalabrutinib and potentially a significantly improved tolerability profile. Now I have to be clear, we don't have head-to-head comparative data between ibrutinib and acalabrutinib yet. That trial has actually been done. We're waiting for the data. We should have that in about another year or so, maybe sometime in the middle of 2021. And we'll have an answer if one of these agents, these two agents, are better than the other. That will be very important to document.